So yeah, I'm gonna start kind of giving you some general information about this really fascinating field of psychedelic-assisted therapy. I'm gonna run us through a PowerPoint. If y'all have questions, please stop me. I'm more than happy to talk during the recording, but if you'd rather talk more privately at the end, we'll do that. Um, I can't obviously talk about everything when it comes to this stuff. It's a lot to go through, but I'm going to try to really focus on being clear about what are the things that are really important about doing this work. So the stuff we've learned in the therapy training and working with folks in this. I'm also going to have some basic harm reduction stuff as part of this, because I think that's always important whenever you're talking about this stuff. And I think it is one of the basic components of how do we make sure these things are safe? Because when you really look at the breadth of clinical research, the risks associated with psychedelics from the 1960s, the sort of Nancy Reagan's fear-mongering stuff, it really doesn't seem to happen if you do proper screening and if you have the right sort of mindset, the right attitudes and opinions about it, and the right setting. If you are in a random environment with lots of random people, you're much more likely to have a really unpleasant experience with these powerful medicines. But there's a lot of simple stuff, and we'll talk about that. So I'm going to share a screen. There we go. All right. Bear with me. All right. So like I was saying, part of the trouble with psychedelics is that these are all Schedule 1 medicines. So what that basically means is every single psychedelic we're going to talk about right now does not have any legal use in the United States, and technically isn't good for even medication or any kind of medical use. These are all things considered harmful, habit forming, and sort of the worst of medicines. The whole point of the research that's been going on is to try to deschedule these medicines. Hopefully MDMA will get put on Schedule 2 or a different schedule so it can actually be used in clinical practice in the next couple of years. Psilocybin has a lot of money behind it, and so they'll probably follow pretty soon after. But we're just going to talk a quick run through of some history stuff. And feel free to stop me if any of this is important to kind of go through in more detail. I'll share this. This is a neat little thing made by this organization. It's at the end of my PowerPoint. There's some links and stuff for it. They did some really great visual history stuff. And this is a great simple representation of the main categories of psychedelic medicine. And for some reason, what's in green is the synthetic and what's in gold is natural. I probably would have flipped it around the opposite way, but most people talk about the ayahuasca, DMT, mescaline, ibogaine, and psilocybin as the plant medicines, So the synthetic versions, MDMA, LSD, ketamine, and there's actually a whole list. There's people who are doing research right now just making small little changes to psychedelics to affect them. There's some great work with inflammation that some folks here at LSU are doing. And, this is a whole new branch of medicine in a lot of ways. The bias most people have, like out in California, you guys have sort of done some decriminalization of plant medicines often, but not necessarily the synthetic versions. Nobody's setting up a lab to manufacture LSD, but, some people seem to lean towards the things that grow from the ground as being naturally safer and less risk, when it's not exactly true. Like ibogaine is pretty risky. It actually, a bunch of clinical trials stopped because of heart issues and things that were going on. And it's sort of one of those interesting little things of, well, if it really helps you with your opiate addiction or your cocaine addiction, maybe the risk is worth it if those are things that can lead to life-threatening changes. This might not be very easy to see, but this is a pretty neat infographic that kind of goes through this idea that these medicines have probably been being used, at least we can record them, back to about 4000 BC. We have cave paintings that are in North Africa of stuff that are pretty clear is psilocybin mushrooms. In the Mesoamerica area, there's been use of peyote and other hallucinogens back into the way back in the BCs. In Europe, most of the psychedelic use is probably more with the DMT variety. There's a lot of the things witches were doing seem to be probably making psychoactive brews and things, these potion cauldrons that they were making probably were synthesizing DMT or other sort of chemicals like that. And so there's a long history that we've been using psychedelics often in religious practice. That's how most other cultures have managed with these medicines, is sort of using it as a periodic, this is for a purpose, this is to connect with God, to sort of connect with your family, your people. This one is another complex graphic that basically is going through all the prohibition stuff. So a lot of these medicines, like LSD, was synthesized, and it was around for a while. I've had the pleasure of meeting people who recall being, 18-year-olds in psychiatry programs and getting sent, like, one guy claims, I don't know if I fully believe him, that they got a kilo of LSD, and LSD is in micrograms, so that is like an obscene amount of that drug. And I'm pretty sure Sandoz Labs probably didn't send them that much, but they used to get these medicines as just figure this out, use it, have fun. And obviously that's part of where the prohibition side came in, is the Tim Learys and a lot of people sort of took it too far. And one of, I think, the best hypotheses about why Americans weren't ready for psychedelics when it hit in the 60s is that we didn't have a sort of container for it. We didn't have a sort of cultural context. We didn't have a way to think about it. And so it became culture and counterculture. And, good old Tricky Dick passed a lot of laws that made these medicines all considered Schedule 1. And, wonderful, great recordings of his paranoid self talking about how he did that because he knew it would get the hippies in jail and they vote against him. And, it's pretty transparent, but because the good thing about the research that was done back in the 50s and the 60s is like thousands of people took LSD in therapy, or even in what they called psychoanemic, which is basically like microdosing. They would give a pretty low dose of LSD and have you sit with your mostly analysts and the deep depth psychology folks. And there was really great results. There's some pretty amazing results with LSD and alcohol. So like, for example, Bill of the folks in the 12-step program, of the two guys who wrote that whole process, he wanted LSD to be one of the things that was part of quitting drinking because he had such a great experience with psychedelics. But all that research became pretty much impossible to do until just recently. So like in the 1990s, people started doing more actual above board research. But, since the 70s, almost all of these medicines have been they used to be career enders for people. Like people who wanted to study psychedelics were pretty much laughed out of most academic circles. And now we actually have a lot of people who are well-respected researchers, and the kind of zeitgeist or cultural perspective of things seems to really be changing, which is pretty exciting. I think there's a lot more people. I get calls all the time from people who are just like, tell me about what you're doing with psychedelics, because they're curious. And it's terrible that we can't include all of these people in a clinical trial because, obviously there's the trouble with clinical research is you have a lot of no's compared to all the yeses about whether you can put someone in there. So, ideally when these medicines hit a more legal standing, we can actually start working with more folks. And I'll kind of walk through why we seem to think these medicines seem to sort of shake up mindsets. They seem to sort of make thinking more flexible. One of the big psychological changes they find in the research is in that big five. It's psychological measures we've done for a long time, it's the openness to experience aspect that seems to change. When people have one dose of psilocybin, they seem to be a lot more open to going to try Ethiopian food, or going to, talk to their grandfather who's deeply racist, and they're like, well, I'm gonna try, let's see what happens. So these are three terms that I think are important to kind of take a second to kind of separate. Hallucinogens was the original rubric that was used to describe these medicines, because basically they cause these subjective perception changes. So you might see the wall melting, you might notice like almost like things are slowed down around you. So your sense of time and space is altered by these medicines. But a lot of folks who were using these medicines, like Humphrey Osmond, who was sort of a friend of Aldous Huxley, and I think he's the one who gave Aldous Huxley mescaline, that got the wonderful book Doors of Perception, that deep philosophical dive into this concept of there's like a reducing valve of perception. That was Aldous Huxley's idea, and psychedelics seem to open that up. So now you experience the world in a more childlike way. And Humphrey Osmond put out the idea of psychedelic, which is, the etymology is mind manifesting. So instead of like you're hallucinating something, maybe really what this is doing is opening a way to relate to your mind and your mental process in a different way. And then we'll talk about this in a little bit more detail later, but as y'all probably mostly nursing folks and folks with more medical experience than me, psychedelics generally work on the serotonin system. And that's something that is pretty important, since most of our antidepressants and a lot of the psychotropics we use also work on that. So the third concept is the entheogen. And I really like this one as a describer of a psychedelic medicine, because it's the sense of the kind of mystical consciousness part of this. It's saying that, like, the theo is the part of that etymology, is that like this medicines that can allow you to connect with God, or your experience of spiritual or the religious. And I think it's one of the three paths we have of how these medicines are going to be able to be used. Number one is sort of decriminalizing, changing the laws, saying everybody can use them, whatever. I really think that's not going to be likely. I think particularly down here in the South, I'm in Louisiana, we're about as conservative and backwards as we can be, and they're terrified that these medicines are going to make people nuts. So that framework of just saying, just trust everybody, they'll use good sense. That's not really the way we've handled drugs in this country. But the second path is this medical model, which I think is great, and I'm invested in it, and I hope this will be something that we can actually bring these medicines out. But is that going to mean only people who have a clinical diagnosis get to use these medicines? And I think a lot of folks in the field are going, well, what about just normal folks, or the worried well, or the sort of people who are just having existential challenges and drama? Like, those people actually are probably ideal candidates for these medicines. If you're not about to fall apart because of your severe depression, you probably don't need as much support and safety to take these medicines. So maybe you don't need 2 doctoral level people to sit with you for 8 hours. There's probably a lot of cheaper ways to do this, like the sort of retreat model people have. And so the third aspect is through the entheogen idea. Like, maybe these medicines could be used as a sort of spiritual practice, sort of like peyote in the Native American church, or like what some people are doing with ayahuasca, like in Soul Quest, and all that seems, I would certainly not try to be in a business doing that right now, unless you had a lot of attorneys behind you. But I do think in the future, I'm almost 44, it's like, of my generation, people my age and younger, it seems like there's a hell of a lot of us who aren't engaged in organized religion, but through these medicines often get experiences of something sacred, something beyond the ordinary experience that feels really important. And a lot of the folks I work with, that's the integration work. Like, how do I make sense of this? I felt unified with God, and I don't even know what God is. I don't have that cultural context to fall back on. I was an agnostic, and now I had this weird idea of light beings, or, it's like, it's hard for people to fit that together. But I do think we're probably going to see a need for new kind of religious ways to use these, or spiritual ways. And I think that's a big opening. Although it also is probably one of the worst things about the psychedelic experience right now with everybody is that also means that it's a great place for a cult leader or, a whole bunch of ego-driven folks to shifting to psychedelic-assisted therapy. The MAPS folks took the psycho out of it. It used to be psychedelic-assisted psychotherapy, and some people abbreviated that as PAP. I personally don't think this should be PAT. I think we got to figure out a better acronym, but psychedelic-assisted therapy, maybe it's a lot more biopsychosocial, and it's not just, you have these 6 criteria for this disorder, you got that disorder, great, move on. And then the third thing that hopefully will change is instead of going, okay, well, you don't sleep, take this pill, you're anxious, take this one, you need to focus better, take this one, and just prescribing a drug for each symptom, which tragically a lot of psychiatrists do. Maybe there's a different therapeutic we could use. Maybe we could find some more holistic strategies. And in the center of this, in psychedelic assisted therapy, that's sort of what we call the default position. It's laying down, reclining, wearing an eye shade, wearing headphones, and kind of being in a relaxed position. And it seems like when you take psychedelics with this setup, it seems to help people really go deep and kind of be kind of in their own head and thinking. So some basic screening. This stuff is pretty simple. I think most people would probably do this automatically. So what all the research has done is screen out severe psychopathology, meaning particularly like things like schizophrenia or bipolar, or even a strong family history of that. And what they found is they've not had any psychotic breaks in any of the clinical studies. And so it seems like if that really is a thing with psychedelics, and I kind of suggest in my own thinking, I kind of wonder if it really has anything to do with the psychedelic, or if it's just, there are some people, like if you guys have ever learned of the diathesis stress model with psychosis, it's this idea that you might have a genetic predisposition, that family history, that sort of way you're wired. And then it's a stressor. It's a thing that happens that kind of pushes you over the edge to delusional or psychotic thinking. And maybe a psychedelic could be that for some people. But I think a lot of times it's not so much as the mechanism of action of the psychedelic that makes someone go nuts. It's more of just a really bad experience without safety that makes someone, just like severe trauma might take someone over that edge. And usually bipolar is ruled out. And that's another thing that there's some debate in the community about, is that really crucial? Because some serotonin energic medicines seem to set off bipolar kind of manic states. And I think that's the fear, that maybe, and you don't want clinical research, any of this stuff to happen, but for most people, we think about that as a way to kind of clear that up, to just like reduce the outcomes or the potential outcomes of a serious psychiatric crisis. And then medical contraindications, obviously this is not something done in a lot of underground stuff people are doing, but, with MDMA, it's sort of that minimum thing of, are you someone who could do a strenuous workout without having a concern with your doctor? So we do heart checkups, things like that. So moving on, set and setting. I want to take a moment to kind of talk about this stuff. If you guys are familiar with this type of work, these are really crucial things. This came from Tim Leary and a lot of his folks at Harvard. And it was the idea that these two things seem to be the most crucial elements of a good experience with psychedelics. So the setting is really clear, like if you're at a music festival with lots of chaotic stuff going on, the odds of you having a crisis or having a really unpleasant experience are pretty high, which is why like the MAPS team has a Zendo clinic where they are at a lot of big festivals, and they have a kind of relaxation tent where people can be and kind of calm down and have someone to talk to, because the safe setting, the environment that all the research is done is sort of like a normal therapy office with a place to recline, calm, neutral things, nothing really dramatic. Is it seems like for some people, being at a laser light show, being at a situation where it's way too stimulating can trigger a bad experience. And so we know if you kind of have calm, familiar kind of container for people, the setting, that greatly increases the odds that this won't be anything negative for somebody. And then the set is a little bit more complex, but this is more, it's kind of like the mindset you're in. So this might be the fact that, you've been stressed out for the last week, or, that might be a bad reason, a good reason not to take a psychedelic. Same sort of thing with maybe being really worried about a lot of stuff. So having the right headspace, and a lot of what we do with preparation is sort of helping people get into that mindset, what to expect, how to manage, moderate anxiety about, particularly for folks who are psychedelic naive. It's pretty important to be like, hey, what might happen? What's going to happen if I have a freak out? The other part is sort of like, it's about like the preferences and intentions. So a lot of people, it's one of the big things with psychedelic therapy. It's what we do in both of the research protocols. It's really about setting a clear intention of what you want to get from this experience. And what we find is that when people are taking a psychedelic to do something deep and to work on old wounds, to feel more connected to people, to, be more embodied, it's a lot better than just to sort of have fun on a Saturday afternoon. Although, psychedelics, like a lot of other drugs, are fun for people to, like you would drink a glass of wine or whatever, but the idea that you're going to get any therapeutic benefit from it, it really depends on the setting and the set, that mindset you have, and what you want to get out of it. We'll talk, some of the theories have some pretty good ways, like the ACE model has this idea of these 3 questions. Really simple, really easy to kind of think about. All right, so psychedelic assisted basics, this is really simple. It's 3 steps, really. Preparation, psychedelic assisted therapy, this would be the med session, and then integration. All clinical research have these 3 aspects. Some people who do this stuff as a sort of side hustle do all 3 of these things, but a lot of them don't really do the preparation right. I've gotten to know some people who really think ayahuasca is a great medicine, and I feel like they don't really do the preparation work in a way that I feel comfortable with. So like we were talking about, like I mentioned, this the 3 questions. I think that's a really smart thing. It's really simple, basic idea, like, what would make this experience meaningful? That's number 1. Like, why do you want to take this medicine? What would give you courage if things got tough? This is an important question to ask someone. How are you going to make it through a hard experience? Because in the ACE model, and it's like acceptance and commitment therapy, this idea of experiential avoidance, it's a fancy way to basically say a lot of people don't like intense emotion. If I'm really experiencing the grief of my mother's passing 20 years ago, I might not want to do that. I might have buried that down deep. And so when I face it, what's going to help you have courage? What's going to help you, one of the phrases that's a great memorable thing is in and through. That's another part of the ACE model and the compass psilocybin. It's the idea of like trusting that if you face some aspect of your mind during a psychedelic experience, don't run away from it. Go into it, experience it, and move through it. That's how you sort of vent emotion. That's how you sort of make healing process. And then the last one is, what would you want in your life after this session? And I think that's also really important to kind of ground someone in the preparation work. So, what's going to make this good for you? How are you going to handle tough stuff? And then, what do you want to do with this in the future? So, prep always has these couple of things that are on this list here. Like, so you're doing the contraindication screening, ideally at least a really good clinical interview. And then psychoed is really important. You know, you want to really have someone understand what's going to happen, what the session's going to look like. Like, we often have people recline on the couch that's used, sort of put the headphones on, put the eye shades on, kind of get a feel of what it's going to look like. And you explain to them that really what you're trying to do is keep them in that default position. So you're going to be reclining, keeping your eye shades on, listening to the music, and often, particularly with psilocybin, almost most of the therapy for the therapist is really about kind of going, wow, being really curious about the person's experience, and then going, hey, how about you go back inside? How about you stay with the experience? And so you want to kind of help them understand that you're not like bored with their experience, but we find it's not that helpful to, in the midst of a really powerful psychedelic experience, it's often ineffable. It's really hard to sort of put to language, really hard to sort of explain. So it's a great way to resist kind of going deeper. Like, you can go, oh, let me tell you about this weird thing I'm seeing that I can't understand. We go, hey, that's really fascinating. Go in deeper. See if you go closer to that. And then flight instructions, that's from Johns Hopkins and Bill Richards, who really is an amazing human being. But it's TLO, trust, let go, and be open. This is like his mantra he teaches people. And it's this idea that trust the experience, trust the medicine, trust the therapist, trust that you're going to come back to where you started. You use a boomerang metaphor that, like, it'll go right back there. And then let go, kind of try to get in deep, and be open to whatever happens. There's a lot more great info about that. We also do touch. So talking about touch ahead of time is really important, because for a lot of people in an intense emotional experience, just holding your hand or sort of like feeling your hand on their shoulder can mean a lot. And so we teach relaxation, because generally when you start with the medicine, the initial part people feel is anxiety, particularly if folks have never taken the medicine. They're kind of scared. They don't know what's going to happen. We're generally non-directive. You're being really careful about bringing your own stuff into it. It's very humanistic and client-focused. And then really a lot of what we do is sort of just making sure someone's safe. So if they want to stand up, tell them to wait a second. Make sure they kind of get their head right before they stand. And then making sure people are drinking, particularly with MDMA. And like I said, it's reminders to go back inside is kind of what we do. Hey, go process that more, get in deeper. Because once the medicine starts arcing and kind of getting out of their system, it makes a lot more sense to start talking about it more. This is from the MAP study. This is kind of that default position I was telling you about. It's really about sort of blocking out the sensory experience, but also really getting into the music. Music seems to really move people emotionally. We talk about it as like music meditation sometimes, particularly with placebo people. Integration, another really important bit. It's about making sense of what happened. The ACE model is really great with this idea that like you start off with chaos and you're helping the person just sort of make sense of what was going on, what the symbols were, what was happening there, and then kind of connecting more toward what does that mean? How does that mean to you? What does that connect to you? And then what do you do to put this into your life? So it's like what was it? I think Pollan's book. If you guys read Michael Pollan's great book, he had this idea of sitting in his garden that everything is communicating and it's all loving and it's great. And that sounds super cheesy, but if that's the truth that you come up with, how do you act like that? How do you change your behavior to make sure you're honoring that? That's how you integrate this stuff. So a lot of it's creative work, writing, journaling, meditating, just you're encouraging the person to keep it in their mind. One of the things we really found in research is just like as a person lays down to go to bed, kind of replay some of the experiences can be really helpful. This is some real basic stuff that's super important. All the research really is about non-directive stuff. So the idea of being a guide for a psychedelic experience, and in a lot of the more religious focused stuff, often you have this shaman who's telling you to do things or doing things in a certain way. It's the model we use in research is really more non-directive. Trust the person knows what's going to happen. Trust that I'll talk about this concept of the inner healing intelligence or the inner healer. They know what to do. The psychedelic maybe just helps them get out of their own way or sort of not be in that sort of ego stance. And to do this work, we also have to be non-pathologizing, and you got to like step back sometimes and realize that what I believe and what I feel doesn't really matter. If someone, has a dream or experience or a vision that is negative to my sense of spirituality or whatever, I've got to be able to sit with them and expect that, what I tell people is that we're just weird. The human mind is strange. It's bizarre. We have all this little collective stuff too, but like a lot of it's strange. That's why I think Freud was an idiot for coming up with the guide of dreams. A goat climbing upstairs means I want to have sex. Come on now. I'm not a Viennese person, like we probably have some other things that might be a little bit more subjective, but being flexible with people. And one of the concepts that really is important is this idea of how consciousness and our sense of self isn't just one thing, that we're really fragmented in a lot of ways, particularly when someone who's got PTSD or someone who's had a lot of trauma. You have this one aspect that you do at work, this one that you with your friend, this one that you as a lover, and we really can be quite different in those experiences. So being okay with that. And a lot of it's about somatic skills, like really being present, helping someone stay in their body, notice their body experience. That's one of those things that when Mesa and I worked together recently, I feel like I was a lot headier than her. And so she would kind of help to balance the person with noticing the body, noticing what's happening there. And I think that's what helps a lot, that you got to kind of do both head and heart kind of things. And you got to be willing to do that. And that's kind of been my growing edge as a cognitive therapist. I'm really in my head. So it's always good to have someone helping along with it. So now I want to kind of touch on theory, and I'm going to kind of run through some of this stuff because I want to be able to have time for everybody to ask questions and to talk about this. So first one, I like this model. This is the more Stan Grof depth psychology stuff. The original psychedelic research was all about this idea, like holotropic breath work. It's this idea that we're always moving towards healing. We're always moving towards life and change. And it's like humanistic psychology. If you get out of the person's way or you help them get out the barriers, they know what to do. And that's the idea with psychedelic healing, is that the person's inner healer is going to get in there. And that sounds super silly to a lot of folks, but it is a really simple thing that most people can really grasp, particularly when they're in a non-ordinary state of consciousness. Trust that your inner healing intelligence, you know what to do. Go with it. If the demon's chasing you, don't run away. Hey, go face it head on. Find out what it wants with you. If you're threatening to be devoured by something, let it eat you. See what happens. What other time can you do this? Because your mind's doing it for a reason. There's a purpose behind the pain, and it's deeply somatic. It's very much a sort of in your body kind of reconnecting with that Cartesian dualism. I think that's what psychedelics seem to do really well for people, is to kind of put you really in the immediate, in the body, in the immediate experience. So Eckhart Harris is one of the researchers in Imperial College in London. I think he's moved around a bit now, but this rebus model I think is really used in a lot of research. It's kind of dense, but it's based on this idea that living systems always move towards order. So our body, our mind is always going to try to streamline, make things more efficient, make things more organized. And the second part is this entropic brain hypothesis, which is really kind of interesting. And it's the idea that, when our brain gets more chaotic, so if you look at the firing in an fMRI machine and you see it all following a very clear pattern, that's usually a set state that we're really comfortable with. But when it's moving in a weird way, different parts of your brain are connecting with other parts of your brain, that's much more connected to a very vivid and deep experience. And it's one of the hypotheses about a lot of non-ordinary states that are found outside of psychedelics, is that maybe in deep meditation, your brain gets more entropic. Maybe if you're running a marathon, your brain gets more entropic, and it's not in that set thing. And this is where that default mode network that's used a lot in this research. And it really, I think it's fascinating, because what they noticed is when you put someone in an fMRI machine, what they always do is say, hey, just sit there and chill out. Wait a second. They scan the brain and then they do whatever experiment. And what they found is this default setting of the brain, self-referential, just sitting there thinking about whatever your day, what you're going to do tomorrow, what's it like to be in this damn fMRI machine, that seems to follow a very clear pattern for people. So you put someone in an fMRI machine over and over, they'll get into this little pattern of functioning. And what it really seems like is psychedelics. When you have that same person take LSD, take MDMA, take DMT, take psilocybin, it just screws that up. And it's one of the hypotheses about ego loss that people talk about, is that maybe what it's doing is just kind of reconnecting this default strategy, this default way of brain functioning. And it's one of the reasons that Eckhart Harris talks about how a lot of our rigid psychedelic or psychiatric problems, so like OCD, depression is a stuckness, I am terrible. The world is a piece of crap. Nobody loves me. I'm stuck in that headspace, and that's why I'm depressed. Anxiety, it's about stuckness. I can't handle this. I'm out of control with this situation. PTSD, it's a stuckness. You're still reliving that. Addiction, I got to use that drug to feel right. And the idea is that maybe he talks about shaking up the snow globe. That if the snow is your neural connections, maybe a psychedelic allows some flexibility. One of the metaphors that he uses is the idea of a snowy hill with kids running their sleds down it. Very soon the sleds start taking these routes. So if you're going down the hill, you're going to get into that one and go. And that's kind of the brain works. We have patterns of dealing with the world. I have ways of dealing with a threat that have worked for me, and so I do them again. It's automatic. It's the idea maybe this is like a fresh coat of snow that just knocks out those grooves, those ruts. Do they come back? Sure, but maybe it gives you a chance of getting that. I'm not going to get into this. This is his idea of predictive coding and a lot of stuff of how the brain seems to move from top down. I'm thinking to feeling and changing it in a different way. So I mentioned the ACE model. I really like this one. In the bibliography for this, when I can share this to you, she's got the manual available online. It's really simple. It's super clear. It's using acceptance and commitment therapy. And she had this idea that when she looked and asked people after taking psilocybin at Imperial College, she found two big categories that people found, is that they were moving from connection or disconnection to connection. So after taking psilocybin just one time, they felt more connected with stuff, with their self, with the world, but they had this pattern of, I was disconnected, now I'm more connected. And then the acceptance of, I didn't want to deal with my feelings, and after taking psilocybin, I can handle my sadness, I can handle my grief, I'm more willing to accept that feeling. And the embody bit is just, I think it's really a basic thing of realizing these medicines affect more than just the headspace. So it allows you to sort of realize that you want to embody feelings. You want to be aware of your feelings. They have a lot of great metaphors. This one's really fun. It's the idea of these stages. And it's, the bottom is the accept, the top is the connect. So you kind of go from letting go, sensing, feeling, the experience of a connected self, meaning and intention. So enacting these bodies. And she's got this great little description that's used to talk to people. It's like your day-to-day life. It's like you're in choppy waves. You don't want to dive down below. It's uncomfortable. It feels scary, but you got to let go and go underneath, and then it gets calmer. You can deal with it. And deep down, there are these gnarly oyster shells or whatever, and those are your traumas. Those are your wounds. And you don't really want to face it. You don't really want to mess with them, crack them open. But if you do, there's a potential that some irritant, has been messed with all the gunk inside an oyster and become something precious. So that's what you're trying to get from a psychedelic experience. And she uses the idea of oysters because oysters are gross. What's inside an oyster is gross. We like to eat them if you like that kind of stuff, but it's not really something that's approaching. Oh yeah, I want that little wiggly stuff. But a pearl, as a pearl of wisdom, as a sort of symbolic understanding of this stuff, it's worth digging down in there and messing through it. And then with that, you can come back to this more connected way of living. And I think it's really beautiful. And it's that acceptance and commitment therapy idea, which uses metaphor in a really powerful way. So, everybody learns this sort of diving metaphor in that. So the last bit I want to talk about is harm reduction. And I also added Eckhart Harris, which he wrote that Drug Use for Grown-Up books that is pretty great. And he said harm reduction makes it seem like drugs are always dangerous. So why not call it health and happiness strategies? So some basic stuff that I've talked about a little bit before. Most people in the field will talk about a bad trip as a psychedelic crisis. And that's usually an intense feeling or something that someone can't handle. And generally, people afterwards will say that those experiences were really cathartic and felt great and were helpful. If you look at trip reports for ayahuasca, most ayahuasca experiences, or a lot of them, would be in the category of a bad trip. But in the process with the support, the end result is sort of a unburdening of something. And so we need to be able to manage that and help someone stick with it and deal with the difficult emotions. Trip sitting is a really cool thing. It's shifted a lot. It used to be talking about guides, but that sort of implies that sitting with someone taking a psychedelic, you have to be active and help them. And usually what happens in those situations is people make mistakes of kind of encouraging somebody to calm down, don't freak out, oh, don't cry, be happy, instead of deep diving. And usually in the proper way, these are folks who are sober, but know the medicine. And then psychedelics and psychotropics, that's something medical folks need to really look at. Like, should someone, wean off most research, people wean off antidepressants, like a certain number of half-lives before they take this. And it seems like that at least make sure that there's not the risk of serotonin syndrome, or at least it makes it a more potent experience. At worst, it kind of stops the serotonin syndrome risk. These are all things that are online resources that are pretty great. Fireside is a really nice experience. It's a phone number that you can text. It's a great real-time support. People will be available. They're really open and good. Dance Safe will send you drug testing equipment. Erowid has a lot of weird stuff on it and great stuff on it, but it's basically about people's experiences. Psychedelic support, that's part I'm a part of. They have a website that's really great to people who've worked in clinical trials in your area, who might know more about these experiences. Tripsafe.org, really great, good stuff. Zendo, I'm kind of mentioned, they've a lot of harm reduction and on festival time, and there are really some great folks in there. Third Wave has a lot of good curated information about psychedelics, and same thing with Fluence. Their Fluence training, they're doing a lot of great stuff, like training people in a much more intense way than what we're doing today about how to work with people, how to integrate stuff, how to put it together. And then I've got a couple of bibliography things about some of the stuff we talked about. This image credit thing is from that psychedelic history stuff, and some of the models. So that was 55 minutes or so of talking at y'all. I guess it's time to open up for some questions. But I appreciate y'all listening to me. I know there's a lot of information to run through in just a short period of time.